Hello friends, welcome to Creative Medicine. In this lecture, we will learn about.
Hello friends, let us now learn some important points about the purine metabolism. Purine metabolism occurs by two pathways. One which is de novo synthesis of purine. Second, we have salvage pathway. If you see in de novo synthesis of purine, this occurs in tissues. Most commonly it occurs in liver. Okay, so that is de novo synthesis of purine most commonly occurs in liver. So first, before we go into the de novo synthesis and salvage pathway, so first we will see the structure of purine. Okay, this is the main structure of purine which I would like to draw. Right, so this is the structure of purine. So in the purines, this N1, so let me name it also, it will be done. So if we name it, this is 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, now it is a 9-member ring, and this N1 is derived from aspartate. In this N1 is derived from aspartate, whereas C2 and C8, okay, both these are derived from tetrahydrofolate, that too N10 formyl tetrahydrofolate. N10 formyl tetrahydrofolate. And then if you see C double bond CN, this is removed by glycine. This is derived from glycine. C double bond CN, this that is C4 C5 and N7 is derived from glycine. C4 C5 N7 is derived from glycine, whereas C6 is derived from carbon dioxide, and C9 N9 and N3 are derived from glutamate. N9 and N3 are derived from glutamate. So now let us now learn first about the de novo synthesis. Okay, in the de novo synthesis, we have ribose 5-phosphate. This ribose 5-phosphate gets converted to phosphoribosal pyrophosphate. Ribose 5-phosphate gets converted to phosphoribosal pyrophosphate, which in the presence of the enzyme phosphoribosal pyrophosphate glutamyl aminotransferase, it forms phosphoribosylamine. This phosphoribosylamine will result in formation of IMP, which is inositol monophosphate, which again gives rise to adenosine monophosphate and guanosine monophosphate. So if you see, we have ribose 5-phosphate which gives rise to phosphoribosal pyrophosphate. This phosphoribosal pyrophosphate, in the presence of phosphoribosal pyrophosphate glutamyl transferase, it gives phosphoribosylamine. This phosphoribosylamine forms inositol monophosphate. This inositol monophosphate is the first nucleotide to be formed in purine synthesis. Okay, and this phosphoribosal pyrophosphate glutamyl transferase is the rate limiting enzyme. Phosphoribosal pyrophosphate glutamyl transferase is the rate limiting enzyme, whereas inositol monophosphate is the first nucleotide to be formed. And if you see the regulating enzymes, there are two regulating enzymes. One which is phosphoribosal glutamyl aminotransferase, which is the rate limiting enzyme, and we have one more enzyme which is called as PRPP synthase, that is phosphoribosal pyrophosphate synthase, which will help in conversion of ribose 5-phosphate to phosphoribosal pyrophosphate. Okay, so this is the regulation of the enzymes. This is about the de novo synthesis. If you see, the next pathway of synthesis is we have salvage pathway. Okay, this salvage pathway is one of the pathway for synthesis of purines from the breakdown products. So if you see, purines gets converted to adenosine. Okay, this adenosine, in the presence of the enzyme adenosine diaminase, it forms ionosine. This ionosine in the presence of this ionosine again forms guanine, and it also forms hypoxanthine. Okay, this guanine and hypoxanthine are also formed from purines. Purines also form guanine and hypoxanthine. So if you see here, hypoxanthine in the presence of the enzyme hypoxanthine guanine phosphoribosyl transferase along with PRPP, it gives inositol monophosphate is formed and inorganic phosphate is released. Similarly, if you see guanine in the presence of the enzyme hypoxanthine guanine phosphoribosyl transferase, it along with the PRPP releasing inorganic phosphate, it forms guanosine monophosphate. Then adenine in the presence of the enzyme adenine phosphoribosyl phosphoribosyl transferase along with phosphoribosyl transferase, it forms adenosine monophosphate and inorganic pathway. So if you inorganic phosphate. So if you see, hypoxanthine in the presence of hypoxanthine guanine phosphoribosyl transferase, it results in IMP, whereas in guanine, again this is also hypoxanthine guanine ribosyl transferase, it forms GMP. Adenine in the presence of adenine phosphoribosyl transferase, it forms AMP. Right. Purines get converted to adenosine. This adenosine in the presence of the enzyme adenosine deaminase, it forms ionosine, which again gets converted to guanine and hypoxanthine. Right. Now, once we have learned about the pathway, there are two diseases which are seen due to the deficiency of enzymes in this pathway. So first, if there is complete deficiency of the disease hypoxanthine guanine phosphoribosyl transferase, there is no conversion of the hypoxanthine or guanine to IMP, that is inosyl monophosphate or guanine monophosphate, and as a result there will be accumulation of hypoxanthine guanine, that is there is accumulation of purines in the purines are accumulated in the blood. Okay, so purines are accumulated in the blood. This hypoxanthine and guanine, both this, because they are accumulated, they will convert themselves to xanthine, which is excreted as uric acid. So in these disorders, HGPRT deficiency, there is increased uric acid is seen. This HGPRT deficiency is given a name called as Lesch-Nyhan syndrome. So in this Lesch-Nyhan syndrome, there is deficiency of the enzyme hypoxanthine guanine phosphoribosyl transferase, and because of this deficiency, there is increased uric acid. Here the patient presents with hyperuricemia, that is increased uric acid. Intellectual disabilities are seen. So in Lesch-Nyhan syndrome, there is you see hyperuricemia, and also you see presence of dysarthric speech, and intellectual disability is seen. Then there can be dystonic movements are seen, and chorioethitosis is seen, and also the most important is self-mutilation disorder is associated with this Lesch-Nyhan syndrome, and there is also megaloblastic anemia is also associated here. Now, how are you going to diagnose it? Diagnosis is by finding the deficiency of these enzymes in RBC. So this is the best diagnosis, but you can also suspect with uric acid. Okay, how are you going to treat it? Treatment is you can give allopurinol. Allopurinol will reduce the uric acid which is increased, and you can do alkalinization of urine. This is also to reduce the uric acid. you can do this alkalinization of urine, right? If there is complete deficiency of this HGPRT, then we get Lesch-Nyhan syndrome. There is one more syndrome where there is partial deficiency of HGPRT, that is hypoxanthine guanine phosphoribosyl transferase. This results in Keeley-Sieg-Miller syndrome. In Keeley-Sieg-Miller syndrome, there is partial deficiency of hypoxanthine guanine ribosyl transferase, and as a result, this hypoxanthine guanine ribosyl transferase is more than 1.5 to 2% of the enzyme is present in this syndrome. So here the patient suffers from obviously increased uric acid is seen, and there will be neurological dysfunction will be present, but this dysfunction will not be as severe as that of Lesch-Nyhan syndrome. Then we have second disorder. If there is deficiency of this enzyme adenosine deaminase, this results in ADA deficiency. That is, it will result in severe combined immunodeficiency occurs because of the deficiency of the enzyme adenosine deaminase. So because this enzyme is deficient, now this adenosine molecule will accumulate. Okay, so as a result, this adenosine will divert to other pathway where adenosine will form deoxyadenosine triphosphate or ATP will form. Okay, so these will inhibit the enzyme called as ribonucleotide reductase is inhibited. Because the ribonucleotide reductase is inhibited, this will decrease all deoxyribonucleotide with nucleotide production, and as a result there will be decreased B and T cells. So because of this ADA deficiency, there will be decreased B and T cells. Obviously, when there is decreased B and T cells, there will be immunity issues are present in the patient suffering from adenosine deaminase. Right? Next, there is one more disorder which occurs due to the deficiency of enzyme adenosine phosphoribosyl enzyme deficiency. So because of the deficiency of adenosine phosphoribosyl transferase, this adenine will increase. This adenine will accumulate, and this adenine gets converted to 2,8-dihydroxyadenine. This adenine will get converted because this adenine is accumulated, and once it is accumulated, it gets converted to 2,8-dihydroxyadenine. Okay, this 2,8-dihydroxyadenine is insoluble. Okay, now if you see the clinical features, there will be urinary calculus formation with crystal urea are seen in this adenosine adenine phosphoribosyl transferase. Because these are insoluble, this will be seen, this will form urinary stones. And the stones which are formed because of this 2,8-dihydroxyadenine will be brownish or yellowish brown in color. Yellowish brown crystals are seen in the urine. Okay, so diagnosis is by finding the enzyme deficiency in urine, and whenever this accumulates in the urine, okay, even this detecting 2,8-dihydroxyadenine in the urine is a good test, and you can also find the enzyme deficiency. Okay, obviously for this also we should have, there will be the same treatment. You will have to give allopurinol, and you can give alkalinization of urine. So these are the pathway, salvage pathway, and the deficiencies associated with the enzymes resulting in diseases. Thank you guys for watching my lecture. Thank you.
Thank you, and thank you for watching.